So this is just 5 basic steps. A lot of you know this, but it's just kind of as a reminder. We've got to collect that information, and certainly we do that in New Zealand. We collect a lot of information. But then we got to take that information and we got to analyze it and think about how interventions for that data can be done. We translate it into action and transcribe it into a document. So again, collect information. We do lots, head to toe. One of the things that I've seen in practice, and I see a lot with some facilities, not everybody, but some, there's a lack of critical thinking. So they're collecting the data really well, but they're not putting the dots together. So an example would be, I've done the weight every month for the last 6 months, but I failed to notice this person has lost 10 kilos. So I haven't done anything about it. Or I've noticed that every day at 3 o'clock, this person falls in their room, and maybe that's when there's decreased staff on the floor because it's handover. You know, it's that kind of critical thinking kind of thing. Or this person's become incontinent, which is unusual, but they're also not as mobile, so maybe I need to toilet them every two hours, you know, to see if we can deal with this continence issue. So it's about putting that data into something that makes sense. So head-to-toe assessments, conversations with patients and relatives and friends. I find talking to families incredibly helpful. I find talking to HCAs incredibly helpful because they're the ones that know these folks better than I do. Observations, of course, chart reviews and notes, and discussion with health team members. Okay, so then the next thing is to analyze what we've got. So again, it's not just recording the data, and this is basic stuff, but I think somehow this is the part that gets missed sometimes, is how do we take that, critically think about that data and put it into action. So where are the areas that resident has trouble and therefore needs to progress, write down the ways the resident could improve, and how that improvement could be measured. That's the most important thing. How would I know it got better? And this is the part that I think, I did have to put it in caps like I was yelling at you, but I think it's important that one of the things about the 20-page care plans is if there's no prioritization, I don't know what's most important. So it's almost in some ways I need a front page that says, you know what, these are the 5 things that are most important for this person. That would make it a lot more transferable and translatable to me as a person who only comes into that facility twice a week. If I knew that these are the top 5 things that we're really trying, it would help the HCAs, it would help the family, it would help all of us to know what are the top issues for this person, not the 20 issues for this person. So how do you know it's a problem? Think how you knew this was an issue. How did you know they were in pain? Did they tell you? Did you observe it? Were you getting, are they getting more medications? Did you use an assessment tool? Is there any related factors? They're more depressed than they ever have been and now they have more pain. I think we've all seen in clinical practice when you relieve depression, how pain really is affected with that. It's amazing sometimes. I had a gentleman who was in massive pain. We did all sorts of things for his pain, and we also treated his depression, and honestly in 2 years he hasn't said anything about the pain since. So it's quite incredible. So what are the related factors? What can be done to make this better? What are the interventions, and how would you know it was getting better? We always have to think. So when I come back in 3 months, when I come back in 6 months, how do I know that this care plan is better? So then you got to translate it. And what is the resident's goal for this area? Now this is one of those tension marks as well in residential aged care. We want to get the goals of the resident, yes. And we also know that at least 50% of residents have some form of cognitive impairment, at least, and often it's 60 or 70% of the residents. How do you incorporate their goals and their preferences into their care plan when they can't tell you what they want? Okay, so that is one of the, I will also say that a lot of people with mild to moderate dementia can absolutely tell me what they want. So there's kind of a real balance here of not disregarding what they have to say and asking them, but also then working with the family about how was this person before? What would they have liked before? What are some of the things that gave them happiness before? I was with a patient last week, and it's a simple thing. So she struggles, she's severe dementia. She struggles with being alone. She yells out when she's alone. But one of the things that she absolutely adores is music. And if you sing to her or she's with music, she calms down. That's a simple thing, is that I will monitor her behavior using this behavior chart by doing music in the afternoons when she's the worst every day. That's the kind of very specific thing that we can do. All right, then transcribe it, common issues. Again, I tend to, this is controversial, I'll just throw it out there. I don't see anything wrong with care planning or SBARs that are rather standardized, as long as they are looked at from the perspective of that person. I just don't think we need to keep rewriting congestive heart failure guidelines over and over again. So I think that's one of the things that we could think about as a sector is there care plans, are there care plans that are standard? There's hydration care plans. There are nutrition care plans. There are very clear evidence-based guides that we could use as care planning. And that's one of the things that I think we could think about as a sector.